Thank you very much for joining the masterclass. And today we will go beyond manual lasers and discuss why navigated laser treatment is rapidly becoming the standard patient not only appreciate but also expect. Laser therapy has been a cornerstone of retinal care for decades. However, traditional manual laser come with challenges. They require high operator skill, can be stressful for patients today are more informed and they often pay out of pocket. For example, I work in a private clinic and a state clinic, and in private clinic they pay fully for themselves. And mostly they choose a navigated laser. They look for technologies that combine safety with innovations. Manual lasers, everything depends on the surgeon ability to keep perfect control. Even with experience, there is a risk of missing spots, so applying too many burns, treatment can be long and fatiguing for both doctor and patient. Here you can see a video of non-contact laser coagulation of peripheral posture tear. It is made in non-contact fashion. It is pre-planned and the caution zones are placed on the optic nerve and macular region. That is why laser will not work in these zones. It's not a simple laser, but as you see, it is made in non-contact fashion. As for non-contact laser, we can perfectly work in those regions, but it is possible also in upper part and lower part. It is like making photos on scanning laser photography. It can be obscured by the eyelashes or eyelid, for example, in 12 o'clock and 6 o'clock. But it is also possible. For example, last week we made laser on a 12 and 10-year child in posture tear. It is possible in every region, but can be not so easy in those. Other regions are excellent. Also, we can use infrared light. Here is a vitreous hemorrhage. And for example, I use infrared light for making vitreolysis. Before making vitreolysis, I can fix flying opacities in vitreous body. This is a posture tear in the upper quadrant, and we shall make it in a non-contact fashion. We use confluent spots on the retina because there is a local retinal detachment. We placed it where the retina is flat, on the border of retinal detachment. We use short pulse duration. It's about 20 milliseconds, and that is why it is very comfortable for the patients. You see the caution zones, and to our experience, it is better if it is possible to go behind the retinal tear in order to laser be more successful. You see the caution zones, and a laser is working beyond the retinal tear. This patient has a slight retinal hemorrhage, and that is no problem for yellow laser to make the laser in such a case. And here you see the result after the laser. You can show the patient the report, and here is 1 month after the laser. Nevertheless, system allows to plan treatment in advance in a fundus image, and the laser automatically navigates to the selected spots. Eye tracking ensures precise delivery even if the patient moves. This transforms procedure into something predictable and reproducible. The main issue when we perform laser is the patient anxiety. And we can show this small video for the patient. Caution zones are placed on the optic nerve and in the foveal region, and then the operator presses the button inside the caution zone, and there is nothing. If the spot in the caution zone, laser doesn't work. Here you can see a conventional laser in pattern manner. You see the limited field of view for the doctor and manually position spots. There is mostly no comprehensive fermentation. As for nevertheless, it gives us the report, which was planned and which is done. In our clinic, mostly patients pay from their pocket by themselves, and the percentage of conventional laser to navigated is about 30 to 70, and patients prefer navigated laser treatment because it's more safe for them. I think that the main issue is safety for the patient. And here they are safe, they see which is done. Also, I think that the navigated laser with the reports gives us an opportunity for more compliance in our patients. For example, after the first panretinal photocoagulation, I show my patient what is done and which must be done in second or third session if they are needed. And they will come for second and third session more obvious. Here is the two microsecond pulsing treatments, which can be easily accessible in the literature. The first one is that a 100 micrometer spot, envelope 100 milliseconds, and duty cycle 10. We work in continuous fashion, make a laser coagulate in continuous fashion, then go to the 10 micropulse duty cycle, and then the power is doubled. For example, we receive the coagulate on a power of 100, so we must go to the 10 micropulse duty cycle and double the energy to 200. But nevertheless, propose another one, which is more safe, and we mostly use this one. The difference is that a titration point is made in 5% duty cycle. You turn on the duty cycle while titrating. 100 or 200 milliseconds, 100 micron spot. Somewhere outside the macula, we receive the titration laser coagulates. We begin from 400 milliwatts and then increase the power in 100 milliwatt step. When we receive the laser coagulate of first degree, we reduce the power minus 70%. So we shall use 30% fluence. Here is a presentation of the patient with diabetic retinopathy and diabetic macular edema. We can overlay fluorescence angiography image. Here we make the titration. After that, we import the thickness map from optical coherence tomography and also place the center of a vascular zone. We can mark it on the OCT anatomically. And then we put it on the laser so we know, even if the macular region is changed because of the edema, we can firmly know where is the foveal avascular zone is placed. So we place the Gaussian zones. Here is a focal laser coagulation in diabetic patient. We use 100 milliseconds pulse duration to close all those microaneurysms. And then we can go after focal part. There is a focal laser. It is very quick. And you see that the patient, she moves with her eye. But the laser, due to the active tracking, makes it strictly on the place where it must be done. Then we go to the titration for micropulse laser. Also, you see the retina before and after applying the laser. It is also set in 5% duty cycle. So we received the laser coagulate on 550 milliwatts. Then we reduce the power to 170. And you see how laser, like in a chess mode, is applying across the edema region in a confluent manner. It is very quick, But in this case, we used contact. You can make non-contact laser in such a case, but there are a lot of spots planned and made. So for patient in such a way is using the contact lenses is much more comfortable. And then we proceed to panretinal photocoagulation. Also, we place the caution zones. Spot size is 390. And we can use a razor to exclude big vessels from panretinal laser. Nevertheless, can be applied in wide range of retinal pathology, diabetic retinopathy, retinal vein occlusion, macular edema, and peripheral lesions. Adds a powerful, more precise options. And for us, it's the best choice. We know that the laser can be stressful not only for the patient, but also for the surgeon. In our publication, Feasibility of Teleguided Training of Retinal Laser Photocoagulation to Optimize Education of Ophthalmology Residents, where we use the survey of the resident, and we can see that mostly median of all residents which were confident for safety of performing of the procedure was about 7.3, 8, 8.4, and overall 9, while performing the laser on Nevertheless system. For us, using navigated laser is shorter treatment times, and it is very short for the patient. Patients are also asking us when the laser will be. And I said, it is finished already. We made it. And they are very, very happy because of this. This is a laser in chronic central serous chorioretinopathy. We see the leakage points, fluorescence angiography. We have old leakage point and active, and use also only active during the treatment. We applied the best fluorescence angiography image, where the spots are tiny and strictly visible. Here we can make it titration points. And we apply 100 micrometer spot on the leakage point according to fluorescence angiography. As to our experience, it is better to make titration points on a fundus image, but make the plan on fluorescence angiography. It is better because on fundus image you can see the picture, the pigment epithelium, no fiber layers, and pigmentation. So you can choose the better area which is better for titration. But the treatment is planned according to the fluorescence angiography image. So then we used 50 milliwatts, 60 milliwatts, 70 milliwatts. And the 60 was where we received the laser coagulate of first degree. So we used 60 milliwatts and closed the points. And here we can see the result of our treatment. And here is a picture before and after treatment in 1 month and a half. The resorption of subretinal fluid is dependent upon the height of subretinal fluid before the procedure. To summarize, patient today expect precision, comfort, and innovation. Nevertheless, brings navigation into retinal laser therapy, turning it into safer, more predictable, and more trusted experience. This is truly beyond manual lasers. So we are going to the more practical part of our session. Now we shall go to focal laser treatment. Here is a patient with chronic central serous chorioretinopathy. You can see the leakage point on the screen. We make a caution zones. Then making titration. It is better done on the fundus image, which is more which is closer on pigmentation to the fovea region. We use mostly 40 milliseconds pulse duration. It's our experience on nevertheless. And then in increment of 10 milliwatt power, we increase the power. We can titrate near the vessels on the upper vessels arcade. For example, I think for this pigmentation, 5 titration point is enough. Then we use fluorescence angiography to plan the treatment. Here we can see the magnification of the spot which will be treated. Then we make the verification that the spot is placed on that place on a fundus, and then go in for treatment. Laser is now in the training mode. It is turned off and it won't work. So we cannot be afraid of. And you see the spots on the retina, which will be titrated. Please open your eyes wider. You see that the patient doesn't blink. You can blink if you want. And after that, we ask not to blink, and the laser make a point and make a photo after it. So we can see the retina before laser and after. You will see a bright flash. The bright flash, the illumination is in infrared now. So it is comfortable for the patient, and he see bright flashes only while titrating, while making photo. So, for example, if we received the laser coagulate of first degree according to Latina on 60 milliwatt, we just pressed here on the screen on 60 milliwatt, and laser also goes to 60 milliwatt. And then we can proceed to treatment. We verify that everything is perfectly overlaid, and then ask the patient not to blink. Don't blink, please. Confirm that everything is okay. And that is it. Everything is done. Then you can see a report. Which energy have we used? What is the titration power? And where we have done the laser. Thank you for your attention, and if you have any questions, we are ready to answer them.